Hepatitis C is a member of a family of viruses called the Flaviviridae. I don't normally mention that, but flaviviruses are actually in the news at the moment. So Zika virus is a flavivirus. I've also in the past worked on viruses like dengue fever, yellow fever. These are viruses that infect and cause a really broad range of diseases. Hepatitis C viruses cause a single disease. As the name implies, they cause inflammation of the liver. But actually, as a virus, as a single virus, it's quite a broad range of viruses. We talk about genotypes, and these genotypes are in a way very distinct viruses, which is one of the reasons why they're so difficult to treat, why we don't yet have a vaccine, and also why they manage to escape our immune system so easily. So hepatitis C is a virus that infects your liver, and once it's in your liver, it very, very quickly makes new viruses that are distinct, that are different. So what's happening inside somebody who's got hepatitis C is the immune system is doing a fantastic job of clearing this virus like it does with all other viruses, but there are new viruses cropping up all the time that it's never seen before, and this is how hepatitis C survives. So unlike HIV, which makes a nice neat little copy of itself and puts it inside your cell, or Hep B, which ties its genetic material into a little circle and puts that inside your liver, Hep C has to keep running to stay still. So we get rid of 10 to the 12 viruses of hepatitis C every day if you've got Hep C. That's an enormous number of viruses. So we're actually producing that number of viruses every day as well. So to cure somebody, we have to tip that balance so that the immune system gets to clear the virus and new virus isn't being produced. Okay, so in prison, hepatitis C accounts for 93% of all infectious disease that we will see. And that's really a lot to do with transmission routes. Okay, so 40% of people going into prison in the UK on an anonymous survey will tell you that they injected drugs in the previous 4 weeks. So injection drug use is a key route of transmission. This is a disease of needles, and injection drug use is a very efficient way of transmitting Hep C. But equally, so would tattooing. So would anything that's in and around the needles that you're using. It's quite common for patients to understand that the needle and the syringe are an issue, but quite often get caught out by the idea that the water that they're using to rinse their needles out might end up having Hep C in it, that the spoon that they're using to cook up the heroin might have Hep C in it. And of course, anything that's going to cause nicks, going to cause blood to be produced, is also a risk. You need to get this concept that blood is the risk. And so sharing razors, if you're going to cut yourself shaving, then somebody else is going to use that razor and cut themselves, then that's a risk. We've got clippers on here as well. Clippers is one of the ones that it can be a constant battle inside a prison. This picture, which forms part of the materials that you'll get to take away with you, this clipper's got a guard on it. What we tend to find is that lots of clippers are used without guards, and you get little nicks there. And so you'll have a wing barber who will shave people and then shave the next person, then shave the next person. They might spray something on it in the hope that that's going to clean things up. But again, that is a key potential route of transmission. And maybe we need to persuade our patients that they don't need to look perfect whilst they're in prison. And maybe they might consider shaving with the guard on, so that they avoid getting nicks and cuts. If you've got poor oral hygiene and you bleed when you brush, and your toothbrush is in any way shared, then that would also be a risk. And quite a lot of people enter prison with fairly poor oral hygiene. Other sorts of routes of transmission that we need to think about would be blood that's spilt during fights. I'm not sure how you communicate that to a patient. I've got hepatitis C, I'm really angry with you, I'm going to fight with you, but I mustn't bite you because I might give you hep C. I'm not sure how that works, but maybe it might make somebody think twice about fighting with somebody. I don't know. We can communicate that lots of people in prison have hepatitis C, and that the risk of sharing equipment is significant. As we discussed earlier, understanding the efficiency of different routes of transmission is important. So direct blood-to-blood contact is the primary route of transmission of hep C. Most people around the world get hep C from hospitals, and use of needles in hospitals if it's unsterile. But in the UK, 90% of people are getting hep C from sharing injection equipment. Now, we quite often tag on the sexual transmission bit, which, as I said earlier, it's true to some extent, but the risk pales next to needles and drug-taking paraphernalia. It's important that we communicate this properly. I saw a training session with some role play that amused me. The nurses were being taught that it's not just needles and syringes, it's also drug-taking paraphernalia. And then they role-played and they said it's not just needles and syringes, it's drug-taking paraphernalia. And I imagine the average patient in prison going, drug-taking what? And I think it's really helpful if we understand what people call things, so if we talk to people in drug services and find out what the local language is around this stuff, then it will just help people understand. Or alternatively, we don't have great big documents with lots of words on, we just go, your spoons and stuff. So by using pictures instead of lots of words that might be difficult to access, then we might be able to communicate this stuff. But the key thing to emphasise is that the biggest risk factor is the injection drug use. The others are potential routes of transmission. Now, there is another aspect to this. One of the key reasons why people won't engage with us in terms of testing and treatment is because they're concerned about stigma. And when we're talking about hepatitis C and the risks of transmission, by saying this is needles and syringes and injection drug use, then it does make a proportion of our patients step away and say, well, that's not me. And those people may still have risk factors and still need to be tested. So balance how you communicate this. I don't want people to leave thinking, well, I'm going to have hepatitis C anyway because I used somebody else's toothbrush once. So talking about this is important, and over a period of time the harm reduction message should get through. But we need to think about how we minimise stigma as we go forward, and we'll talk more about that in the afternoon sessions. Okay, so hepatitis C. When I first started working on hep C, we started to test people. The virus had just been identified, we started to test people, and we found that some people had perfectly normal livers, some people had cirrhosis, some people had liver cancer, and you end up building this map of the proportions of people who are at different points. And we had this belief at the time that you got hepatitis C and some people would end up in this box and some people would end up in that box, and we didn't know how that they got there. What we've learned over the last 25 years or so is that really what's the case is this is a progressive disease. It will go at different speeds in different people. So if you're young when you're infected, if you're female, so being male is an accelerating factor. Am I the only person in this room that feels that's unfair? Being overweight is an accelerating factor. Drinking alcohol, not surprisingly, is an accelerating factor. But getting HIV, getting hepatitis A, getting hepatitis B, also accelerating factors. We were involved in a study in Brighton where they were testing and treating in the local drug service. And they found that 23% of the patients within that service were cirrhotic. And yet the average age of the people surveyed was 38. Right? If you go for it, you can become cirrhotic really quite young. And so hepatitis C will reduce the length of your life if you're adding in these other factors. Smoking marijuana also accelerates fibrosis. So the speed with which these things go depends on lots of lifestyle factors as well. So if we can educate people about the lifestyle factors, then they can reduce the impact of their disease, even if they choose not to be treated today. Okay, so what's going on? So hepatitis C, hepatitis B infects the liver and it causes inflammation. I think of two livers, right? There's the liver that exists in a textbook like that one, and then there's a liver you see when you go to Tesco. Yeah? If you go to Tesco, you've got a cow's liver or a sheep's liver or something, and if you poke at it, you're not supposed to, but if you do, right, it kind of wibbles, right? If it gets inflamed, it's going to become a little bit stiffer. If it starts to become scarred, it's going to become hard. Here you've got a liver that is so badly scarred that the bits that are still alive are sectioned off. What you can see, the lumpiness to it, is where you've got healthy liver that's trying to regrow, and it's fighting against these bands of fibrosis, these bands of scar tissue. So when I was at medical school, this was called a hobnail liver. I can't imagine that there was anybody in the room who knew what a hobnail boot was anyway. But you kind of get the idea. You've got these lumps. This is somebody's liver mid-transplant, and you can kind of see that you've got these darker lumps that are sticking out, and these paler bits which are the fibrosed bits. If you imagine that liver in Tesco, if we were to take it and to wrap elastic bands around it, then it would increase the pressure of it, it would make it stiffer. And one of the ways that we can tell how badly fibrosed somebody's liver is actually to give it a bit of a wibble. That's what a FibroScan does. Yeah? You put a probe against the side of somebody's liver and it gives it a little bit of a flick. The length of time it takes for that wave to get down the far end and come back again is a measure of how stiff that liver is. If it's like the one in Tesco, it'll be a slow wave, and it'll have a low number, and if it comes back really quickly, it's like the liver if you've taken it home and fried it, and it'll be really stiff, and that wave will come back really quickly. So if patients are left with cirrhosis, and even some patients who have before cirrhosis, they can develop hepatocellular carcinoma. The idea of the game really is to prevent people becoming cirrhotic. We need to make sure that we identify people who are cirrhotic so we can get them treated to prevent the hepatocellular carcinoma, to prevent the transplant. So hepatitis C is known as the silent disease, the silent killer. We know, if you go out on a Friday night with your friends and you have a couple of gin and tonics, it doesn't hurt. We all know that drinking alcohol damages our liver, but it doesn't hurt. We don't have the right kind of nerves in our liver to tell us that we're damaging our liver. So if you've got hepatitis C infection, you generally don't know. There have been transfusion accidents where large numbers of people have become infected with Hep C. I was involved in tracing a case in Ireland where mums had been given anti-D immunoglobulin. Those mums knew exactly when they'd been given that antibody, and therefore exactly when they'd got their hepatitis C. And some of them recall kind of flu-y symptoms and feeling sick. Some of them talked about being sick. To be perfectly honest, if every time somebody felt a bit sick or felt they had sort of flu-y symptoms, if we thought, aha, you've got hepatitis C, I can't see that being particularly diagnostic. So what tends to happen is people either don't remember this at all, perhaps it doesn't even happen, and generally they'll put many of these symptoms down to lifestyle things, especially in a population who are perhaps injecting drugs. Feeling a bit rough in the morning is not that unusual. You know, having achy joints, feeling a bit fluey. Yeah. hepatitis C infects your liver, but it actually, being chronically infected with anything, having this long-term infection, causes symptoms that are all over the body. If you're constantly producing antibodies to fight this infection, then things can go wrong. So I remember part of my job used to be in the lab would be separating out the bloods so that we could take the serum off, so that we could test it for hepatitis C. And I remember there were these patients, and they always seemed to have Italian names. And you'd take their bloods out of the fridge and you'd spin them and they wouldn't separate out. And we discovered later on that this was because they had a condition called mixed cryoglobulinemia, where the antibodies were binding to the antibodies, and they kind of clog up so that the red blood cells wouldn't separate down. More importantly, what happens is that those antibodies then clog up where the blood vessels get narrow, so in their kidneys, so they would end up with kidney damage. Now, from my perspective, if I left them in somewhere warm for a bit, this would be fine and they would separate out. But for those patients, that's an issue. So we see renal issues with hepatitis C. We see problems with antibodies binding to things that they shouldn't do. So you get rashes, you get autoimmune rashes, you get a condition called Sjögren's syndrome, which is where the antibodies are binding to the tear ducts. So you end up with dry eyes. So you end up with eye issues. You can get antibodies that are binding inside blood vessels and causing inflammation. I remember meeting a guy from Singapore who was telling me about how his patient was slowly losing his fingers because the blood vessels in his fingers were so clogged up by this necrotizing vasculitis that he was losing his fingers. So although this is a liver disease, there are symptoms that are all over the place. What sorts of things do so Sherelle, what sort of things do you see in patients who are quite chronic? What things?
We do have some with renal problems, don't we? And a lot, to be honest, is more sort of muscular weakness, things like that. We see a few of all of those, really, if I'm honest, and the diabetes, but I'd say the renal ones probably.
I can think of quite a few that have got lichen planus as well.
Yeah.
So how would you spot lichen planus?
Well, I wouldn't, but
dermatologists
generally, they've usually already been diagnosed.
They've
normally. I've not had anybody say to me, "Oh, I've got this funny thing with my mouth. I don't know what it is. Can you have a look?" It's usually something that's already been picked up. But often it's these other things that then lead to diagnosis of Hep C. So,
yeah, I mean, we've got a renal lady actually who's had 3 renal transplants. And it's not hepatitis C actually, it's hepatitis E that she's got. So it's only because of all the renal problems that's come to light that she's got that. So it could be the other way around.
I think it's something to remember when we're trying to persuade people to have a test. Even if they say no initially, there may well be other health complications that they have, and that you can use those as an opportunity to have a conversation with that patient. So I was running a similar session with Jane Dodd up in Manchester, and she was talking about she had a patient who came in and they had leg ulcers, and they tried everything for these leg ulcers, and she said to the patient, have you thought about having a test for hepatitis C? And they tested this guy for his Hep C, and they treated his Hep C, and the leg ulcers went away. And I'm not saying Hep C treatment is a treatment for leg ulcers, but I think as people start to look after their health more generally, then some of the non-specific stuff that crops up will go away. And we see that on treatment. Now we've got these newer drugs that don't have so many other harsh side effects, that you end up with patients saying, the virus is gone, I feel so much better, this fog that I had in my mind is gone, I can think clearly. But if we imagine we've got this situation whereby the liver is becoming more and more fibrosed, and you've got this almost like bands of fibrosis around the liver, you would imagine that what's happening inside that liver is the pressure increases. And that's exactly what happens. We get this thing called portal pressure. And what it does is it causes, for example, blood vessels to start bursting. So The darker dots there are bleeding blood vessels into the esophagus, and so you've got a scope down the esophagus, and they'll need to stop those bleeds. That patient might throw up blood. You can also, slightly more rarely but quite spectacular, is Caput Medusa. So Greek mythology, Medusa was the lady with the snakes for hair. So Medusa's head. What you've got there are the blood vessels, kind of like varicose veins. The blood vessels have become quite distended around this guy's liver. So it looks like there's a snake underneath his tummy. Another symptom that you might see is spider nevi. So you see little stars of blood vessels, and if you poke them in the middle, then they blanch. Other things that you might spot, because you're close to the patients, if you look at hands, if you're well, then you'll tend to find that if you put your thumbs together like this, then you'll see a nice gap. As your liver starts to fail, you tend to get clubbing, so you'll end up with the nails touching each other rather than there being that gap. Another end stage thing that hepatologists ask their patients to do is to extend their hands like this, and liver patients, we have what's called liver flap. They tend to start doing this, they can't hold their hands up like that. Just wandering around a town in the northwest of England, I don't want to name it for the sake of stereotyping people. A number of people I walk past, great big belly, yellow eyes. I'm sat there thinking, do you realise how screwed your liver is? Now, it could have been alcohol. So liver controls fluid balance. So you end up with fluid accumulating in the belly, in the legs, and it needs to be drained off. This guy's using a syringe, but you can drain litres off people. Impacts on your organs, causes organ damage, and needs to be drained away. Another complication of end-stage disease is that you get jaundice. So thousands of your red blood cells are dying every day, and it's your liver's job to clear everything away. Now, red blood cells are obviously red, but they're red because they contain something called heme. Heme is red because it's got iron in it. If you take the iron away, it's green. It's greeny yellow colour, and it's fat soluble. So if your liver isn't working, it doesn't get broken down, so it accumulates under your skin. So what should happen is the yellow should end up in your wee, but it doesn't. Here it ends up under your skin, and it irritates, so you end up with patients being itchy. And it's because the bilirubin is irritating. Now, if you have dark skin, then you tend to spot it more in the sclera. Dentists spot jaundice because your gums go yellow as well. So these are the things that happen when people are what we call decompensated, where their liver has really stopped working. The other thing that will happen is patients will become quite confused. They'll end up with encephalopathy. So what we need to do is we need to cure them of their hepatitis C. Sounds very, very simple. So I said at the start that when I started this journey, I was working with interferon. We were treating patients for 6 months with interferon, and we were curing about 10% of them. What we found was that when I got their blood samples, we would obviously test them before they were treated, and then we would test them periodically through treatment, and then we'd follow them up when we stopped treatment. What I noticed was that some patients, nothing would happen. For around about 40% of patients, their virus went down to undetectable, and it was undetectable throughout treatment. And about 3/4 of those people, as soon as you took the interferon away, the virus would come back pretty much as quickly as it had gone away. So we call that going down a virological response, a response in the virus, virological response. And if it stayed down when we took the drug away, we call it a sustained virological response. And the amount of time we had waited and tested, we then put a number at the end, So at the time we were working with SVR 24, which meant that that patient's virus hadn't come back for 24 weeks. Now, we believe that if the virus hasn't come back for 12 weeks, probably isn't going to come back. Now that doesn't mean that that patient is immune to hepatitis C. If you go and share needles with somebody else and you get infected, you will have hepatitis C. So we see patients where the virus comes back 3 years later and is a different genotype, and they're saying, no, I've never shared with anybody. You can't say for certain that it isn't the virus coming back and it wasn't hidden in some corner, but if you've got an SVR12, maybe you want to check after 24 weeks again, but that patient's cured, right? So the C for hepatitis C is cured because you can cure them with tablets. Yeah, the patients will worry about, well, will it come back? Well, you need to make sure that you don't get reinfected, but you've been cured and your liver should recover. So successful therapy we describe as SVR, sustained virological response. When you explain that to a patient, we're talking about them being cured. Yeah? So here's the hepatitis C life cycle. Again, we're not going to do it in great detail, but essentially what we're trying to do is the same, and that's to form hurdles around the life cycle so we can block it in multiple places. With interferon, what we were doing was generally boosting the immune system, and it allowed the immune system to come in and clear the virus. With ribavirin, we don't really know how ribavirin works. A couple of different theories. But now we've got drugs that attack specific parts of the life cycle. If it ends Previr, it's inhibiting the protease, Previr protease. If it's Buvir, it's inhibiting this enzyme called NS5B, Buvir B. So the other class are the ASVIRs. So what hepatitis C does is it's got a genome that's made of RNA, and what it does is it makes a copy of that, and to do that it uses this enzyme called the polymerase, and so the Buvirs stop it making new copies of itself. Once it's made that RNA, the other thing it can do is make its protein, and it makes its protein all in one long string, and then it needs a protease that it makes to chop up that string into all the different parts. So the protease inhibitors inhibit that part of the process. NS5A, there are lots of papers saying what it does, but actually nobody really understands properly. So you've got 3 stages in the life cycle where we've got inhibitors that can block, and what we do is use combinations. Depending on how robust a block it is, you might need to use a combination of a couple, or you might need to use a combination of more than 2. Okay, so a lot of information on this slide. I'm not going to take you through it in any detail. This is just for me to flag that with hepatitis C we talk about genotypes. If we just focus on the United Kingdom, then around about 45% of all of our infections are genotype 1, and around about 45 are genotype 3. We see some genotype 2s. Depending on where people came from, then we see some genotype 4s. Northwest London, which is where I used to work, we used to see quite a lot of genotype 4, mainly in the population from Egypt. We did a study specifically of Egyptians back in the 1990s, and we found very high levels of Hep C in Egypt, and they almost all had genotype 4. So we have this mixture of different genotypes, and what patients will come to you and go, oh, I've got the bad one. Oh, I've got the bad one. Actually, we've got treatments for all of them, and depending on which treatment you look at, different treatments will have different success rates. So interferon, for example, was very good at treating genotype 2, not bad at treating genotype 3, but wasn't very good at treating genotype 1. Some of the newer drugs are better at treating genotype 1 and kind of flip that around a little bit. But what you need to remember to communicate to patients is we need to know your genotype so that we can choose the best treatment for you. This is quite a broad range of different viruses, and different treatments, at least at the moment, will work differently depending on your genotype. Now, if you're sharing a cell with another guy and he's being treated for his hep C and he gets tablets, and you still have to have interferon, that's going to feel pretty unfair. So it's important to communicate that bit, to say it's because he's been given the treatment that's best for him, because of the virus he's got, and you've got the treatment that's best for you. Now, we will move towards an era where we can treat all of them with tablets, and a lot of this will go away. Exactly when that's going to happen, probably 2 or 3 years away yet. So at the moment, that's the key message. All of these genotypes are treatable. We just need to select the best treatment for you and the best timing of that treatment. Okay, so genotype impacts on which treatment you get. The other thing that impacts on which treatment you get is what stage your disease is at. If you remember the river, we've got people who've recently injected become infected, and quite often they're going to have no evidence of fibrosis. And you'll have people who you'll come across whose livers are failing, and everything in between. And we need to be able to tell where people are, because it tells us what urgency we have around their treatment, but it also tells us which treatment is best for them. So there are 3 ways that we can stage people. One is generally regarded as the gold standard, which would be FibroScan. So that's the one where they give your liver a flick. You see you've got this probe, it vibrates your liver, and the machine goes bleep and spits out a number, and then we say whether you're cirrhotic or not based on that number. For most of my career, what we did was to take really quite a large needle and stick it into somebody's liver, kind of like a cork borer, pull a bit out, and then we'd get this bloke called Rob to look at it under the microscope, and Rob would tell us what stage you were at. And we only ever used Rob because if we asked somebody else, they'd give us a different answer for the same. And part of the problem with that is if you think back to this liver, it would depend on where you went in as to what that picture looked like. And you might just happen to hit a really healthy bit and come back and say, oh no, you don't have. So the advantage of FibroScan is it's sampling the whole liver. The disadvantage of FibroScan is not everybody's got one where they need it, right? So if you've got this prisoner, and the average stay for somebody who injects drugs in the UK in prison is 4 months. Actually, for active injectors, it's nearer 3 months, right? So the idea that you're going to sit around and wait for it to be convenient for the prison to take that prisoner out so they can have their FibroScan, and then they're back in prison, and then they go back again. We want to try and speed things up as best we can. If you don't have a FibroScan, another option is to take venous blood and to use serum markers to stage that patient. Actually, in Pentonville, this is their routine. So they use ELF and FIV4 to stage all of their patients. Part of the reason for that is they have very high turnover of patients, so they need the speed. APRI, for example, you need ASTs, ALTs and platelets. So if you send off for blood biochemistry, you get those 3 numbers back, you Google APRI calculator and you put the 3 numbers in, and it gives you a number and it tells you whether they're cirrhotic or not. So that's another way that you can use, and in all of the current policies, that's a perfectly valid thing to do as well. So if you don't have access to a FibroScan, wouldn't necessarily recommend going to needle biopsy. I do know of a prison that is biopsying still. Now, one of the things your liver does is make your clotting factors. So there is a risk with biopsy that people will bleed, which in a secondary care hospital, you might be able to manage that reasonably well. In prison, it could be quite a challenge. So suggestion is, if you don't have access to a FibroScan, consider serum markers, and it's not that hard to do. Okay, so what's changing? So it says here the current standard of care. It's not really true anymore. Standard of care a couple of years ago was interferon, which made people feel like they had flu. We then added in ribavirin, which gave people anemia, gave people a cough, couldn't sleep at night. But the combination of those two drugs meant that we went from that 10% to 40%. In 2011, a new class of direct-acting antivirals, Previrs, came in. Massive piece of innovation, took us from 40% up to 70%. So again, what we're doing is we're getting this improvement in response rate, but each time we added in these drugs, it made the treatment more complicated, and it made it more complicated because the adverse event burden went up. So a side effect of these drugs, you may well remember, was a particularly itchy bottom. But also, taking them 2 or 3 times a day with meals containing a Big Mac's worth of fat. Now, in a prison environment, that's really challenging to get optimal treatment. And to hit the 70% is a challenge. Interestingly enough, the prison data was pretty good. So as a group of patients, they take treatment even when it's as tough as that. Now, we're moving away from that world. The protease inhibitors that are used now are much easier to take. We're now moving towards combinations that are all oral and are shorter duration, and that shorter duration is really important. We're moving towards an era where the side effect burden is much smaller, the risk of drug-drug interactions is much smaller, treatment durations are much smaller. It ought to be easy, right? Actually, the challenge is getting people tested so that they can be linked into care. And part of the reason why it's a challenge is because people don't want to be seen as having hepatitis C. They don't want to be diagnosed because they fear that somebody's going to stick a dirty grape needle in the side of them. They don't want the treatment because it's worse than the rattle. Yeah? But actually, that's not actually true. We can stage your disease with a FibroScan. We can treat you with tablets. And we need patients to learn over time that the treatment is much more accessible. It's much easier for us to deliver. They just need to accept the test and move into treatment. So things to remember about Hep C are that this is the one that we can cure, and that we're moving into an era now where we've got all oral treatment for lots of patients. From the 23rd of February, patients will have access to all oral treatment with genotype 1 even if they're non-cirrhotic, and that's the majority of our population in prison. So Hep C is the key one. It's really important that we leave here feeling that we know what we're talking about Hep C.